You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
This episode is supported by an educational grant from Genentech, a member of the Roche Group. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Chelsea Backler, Oncology Clinical Specialist at ONS. Today, I'm joined by Dr. Lisa Kennedy-Sheldon, Clinical and Scientific Affairs Liaison at the Oncology Nursing Society, to discuss the impact of the COVID-19 pandemic on the administration of antineoplastics. ONS staff evaluated the risks and benefits of home infusion of antineoplastic therapy and what should be taken into account to develop this site of care delivery. We have seen a paradigm shift where regimens typically infused in one setting are shifted to another to reduce the volume of patients in the inpatient and ambulatory clinics. Telehealth visits are replacing in-person visits, and most recently, there's been discussion of home infusion of antineoplastic therapy. The ONS Board of Directors recently released a new position statement on home infusion that provides the requirements in models of care for home infusion that covers nurse training, safe handling, and policies and procedures. A link to that statement is in the episode notes. Thank you so much for being with us today, Lisa.
Thank you, Chelsea. It's a pleasure to be here.
Great. So let's start a little bit by discussing the role home infusion has kind of traditionally played in cancer care prior to the COVID-19 pandemic. So what kinds of cancer care are generally provided in the home?
So prior to the pandemic, we had certainly a large workforce of visiting nurses and increasingly infusion nurses taking care of people with cancer in the home setting. Often this was related to supportive care originally, so that would be the port maintenance and flushing, changing of dressings, injections, subcutaneous and intramuscular injections of things like growth factors, or Lovenox after DVTs and PEs, androgen deprivation therapies, things like Leuprolide for prostate cancer. So injections in general were considered something you can give in the home setting. And finally, in the supportive care environment, and coming also out of the hospice and palliative care environment, we saw an increase in the infusion of things like intravenous fluids for dehydration, administration of pain medicines, steroids, and even anti-nausea medicines in the home setting.
So there's definitely a lot of cares that can and have been occurring for people with cancer in the home. You mentioned, the types of nurses that were involved. Can you talk just a little bit more about who's typically been involved in administering these cares in the home?
Yeah, sure. So let's talk about kind of like the three different groups of people who've been doing home care that would involve, generically speaking, injections, intravenous fluids, access and maintenance of venous access devices. And traditionally, those were visiting nurses. We saw, of course, over the last probably 15 years, an increase in the number of infusion nurses working for infusion companies. And we've seen an increase, of course, in the number of 5FU, 5-fluorouracil pumps being started, maybe in an outpatient cancer center, patients going home with these pumps for 48, 72 hours, and then having an infusion nurse come in and discontinue the pumps, make sure that they had safe disposal of those medications, and getting more involved. So sort of a different group of nurses than the traditional visiting nurses providing that care in the home setting. Now, increasingly, we're seeing, what is the need for nurses who have training in oncology specifically and in the safe handling and administration of antineoplastic cancer drugs in the home setting. So we're seeing a change happening for registered nurses who provide care in the home setting, from moving from just a traditional visiting nurse or a hospice or palliative care nurse, we don't want to leave them out, and then increasing a specialized group of nurses, infusion nurses.
Great. Okay. And so you're kind of mentioning that we're seeing a shift. So could we talk a little bit more about maybe the shift that's occurring since the COVID-19 pandemic and the utilization of home infusion for people with cancer. What would you say are the main driving factors in this shift to start doing some more of these infusions in the home?
Yeah. So even prior to COVID-19, it's, we'll divide the world up into pre-COVID and post-COVID. Prior to COVID-19, we saw the emergence of what were cancer at home programs arising mostly out of academic medical centers, comprehensive cancer centers, such as University of Pennsylvania's Cancer Care at Home program or the Hopkins program, which actually originally started in primary care and extended into cancer care. And finally, I want to certainly celebrate the Huntsman at Home program out of the University of Utah, where former ONS president Kathy Mooney is a co-investigator. So you can see that there was an emergence of these cancer care at home programs starting as a way to be able to reach people in their homes, particularly for these longer infusions or for short treatments like growth factors that could be administered in the home setting. Now, post-COVID. Post-COVID, certainly the world has changed since March 13th, 2020, when we've tried to decide how best to deliver cancer treatment to people with cancer. As we all know, people with cancer are at higher risk for COVID infection, whether that's just because of their particular type of cancer, such as lung cancers or hematologic cancers that would have a suppressed immune system, or whether that's related maybe to the particular treatments that suppress the immune system, or maybe it's related to age. As we know, age is a risk factor for COVID infection. In fact, we saw in the American Association of Cancer Research COVID meeting, which was held the third week in July, that the risk for people with cancer on treatment, any treatment, chemotherapy, immunotherapy, getting a COVID infection is 2.5 times higher than the normal population who do not have cancer and are not receiving treatment. It's a very substantial risk. So what does this have to do with home infusion? If you're at higher risk for COVID infection and the many different adverse events and even life-threatening and life-ending events that can happen from COVID infection, we want to minimize that as much as possible. And one of the ways to do that is to keep patients away from hospitals where they have an increased risk of being exposed to COVID-19, whether that's from other patients, the general public in the lobby, or even the staff. We want to make sure that we're minimizing risk to the COVID infection. So this has created an increase in interest in how do we safely give cancer treatment, not in a hospital setting, not in an outpatient center, but in the patient's own home, and decrease the number of times they have to come to the hospital.
So really, one of the major benefits is potentially reducing that risk of exposing someone with cancer to COVID if they're coming into the clinic or the infusion center for infusion. So obviously, big benefit there potentially for them. Are there any other benefits of transitioning someone to infusions or supportive cares into the home?
There are lots of reasons to bring care to the home. And it's not just about the delivery of the treatment itself. It allows the provider, nurse, visiting nurse, sometimes nurse practitioners or physician's assistants, to get a really close-up view of not only the patient and how they look and how they're doing, but how they're managing in the home setting. Do they have access to food, clean water, heat? What is their support systems and how are they contributing to the care of the patient? So that's actually a unique aspect of going into the homes that we don't do when we bring patients into our own created, sterile, very set up facilities in an outpatient cancer center or even in an inpatient hospital. So that's an interesting part of going into the home that is kind of grows out of this work, right? And anybody like Chelsea, when you go into the home setting, you get a whole nother view.
Right. Yeah. And we chatted a little bit about this topic previously. And so we talked a little bit about my previous life of being a home infusion nurse. And it was so curious to me to see patients who I had seen in our clinic infusion center for a long time coming in, and then we were transitioning them to the home for one reason or another. And then I'd go into their home to help them set up their pumps or do whatever it was. And it just seemed like their walls came down a little bit, or they were just so at ease that there were things I was able to see or get feedback from them on things that I'm like, well, gosh, you didn't mention that when you were in the clinic. So I think it's just something really special about being in that patient's environment and seeing those things that you wouldn't normally see and maybe wouldn't think to ask about, things like power outlets. Like, do you have plenty of access to power outlets or a backup plan in case you lose power and you have a pump that's relying on electricity? Those are the things that it's hard for you to think about when you're in the clinic setting, that just, it opens your eyes so much more when you get into that patient's home. So definitely, I agree with you. There's a lot of other benefits that come along with it when we start getting into people's homes.
Those are great points. And really, it does provide you with a very much a holistic perspective about a person and their environment and the support people around them that are helping to take care of them.
Absolutely. And I think now, especially, with maybe some clinics having different policies about visitors coming into appointments with them, if you're going into the home, the family and the caregivers are there. And so you have that extra layer of support and extra sets of ears there for education. And so I definitely can see some additional benefits that way too, with the caregiver support being right there. So kind of on the heels of that, I guess, of the benefits, let's talk specifically about nurses. So nurses that have been doing maybe that more specialized infusion therapy in the home, like home infusion nurses specifically, do you think that that group of individuals can safely administer antineoplastics in the home? Or do you think there might be education or training that they would need in addition? Or is this something that really requires a chemoimmunotherapy competent nurse from maybe like an outpatient infusion clinic to go into the home?
Yeah, we've learned a lot over, the last 15 years working with the infusion nurses who go into the home, say for the 5 fluorouracil, 5 FU pumps. And we've learned a lot about safe handling and disposal. We've learned a lot about what happens when the pump disconnects and the tubing leaks 5FU all over the bed or the chair in the home setting, and how to take care of spills in the home. But that's only one part, the safe handling and administration. There's a whole world of oncology care in general. And we know that cancer is many, many different diagnoses. And the more we have precision oncology and targeted therapies, we realize we're going to have many more treatments for all these different types of cancer. So we're giving them the correct treatment, the precise treatment for whatever their type of cancer is. And we're learning a lot about these drugs. And some of them, we're finding, the first time we give it to them, they might have a reaction. They might have such a severe reaction they require an EpiPen or oxygen or emergency services, or frankly, can be potentially life-threatening. We also know that some of these drugs, many months later, some of them like carboplatin, 6-7 cycles in, all of a sudden have a life-threatening reaction, a hypersensitivity reaction. We don't know why exactly that happens. And now that we have immuno-oncology agents, we have another new dimension in what happens with adverse events from immuno-oncology agents, such as pembrolizumab. So commonly used originally in the non-small cell lung cancer setting, certainly for many more cancers now. We know that they develop more reactions specifically related to the immuno-oncology portion of it, so the immunoactive component of those drugs, where they start to attack over time specific organs, particularly endocrine organs, but it can also be things like the lungs. So an immuno-oncology adverse event like pneumonitis or hypo or hyperthyroidism. This is concerning. And I'm going to give an example. And I know Chelsea and I have discussed this, and I think it's kind of an interesting example where expertise about a cancer as well as the drugs can actually inform patient assessment in the home. So in the era of COVID, we know that a cough is a symptom, right, of COVID. In the world of pembrolizumab and lung cancer, particularly non-small cell lung cancer, we see many patients have a cough, maybe related to COPD they developed from maybe a previous history of cigarette smoking. Well, also cough can be a symptom of pneumonitis from an immuno-oncology agent, particularly the checkpoint inhibitors like pembrolizumab. unless the nurse who's doing the assessment going into the home has an idea how to assess for cough in a person with lung cancer receiving a checkpoint inhibitor during the era of COVID, they could miss that. So we want to make sure that the nurses who are going into the homes and administering antineoplastic agents understand the neoplasm, as well as the safe handling, administration, and disposal of many of these agents, which may be hazardous.
Definitely. I think that you're really illustrating a good point of it's not just giving the drug, cleaning up, making sure you're disposing safely and leaving. You're alluding to something that we in oncology nursing have known for a long time. Like, it's about the patient and their specific type of cancer and how that drug is going to interact with the other drugs that they're on, and just a whole host of other considerations besides just, starting an IV and giving the drug and discontinuing it and going on your way. So there's definitely a lot of considerations there to think about, and whether the individual administering that drug or taking care of that person knows all those aspects and is able to kind of do the full assessments and report back on anything that's concerning or getting them to the right level of care. There's just a lot of things at play for sure.
If you think about it, there's actually two sets of competence. One is oncology competence, to understand cancer as the numerous diseases that it is and the way that it not only presents, but the kind of symptoms that can occur from the cancer. And then there's the safe handling, administration, and disposal of particular antineoplastic agents, and an understanding of the symptoms, adverse events, pre-medicines, post-hydration, all those considerations that go into administering chemotherapy, immunotherapy.
Definitely. And I think too, to the flip side of this is, so we're definitely talking about where maybe an oncology nurse who has those competencies would be able to identify and do the assessments that they need to do for this particular patient. But I think on the flip side of that is, I don't know that you could just take an oncology nurse from an outpatient infusion center and say, tomorrow you're going to go into somebody's house and give this drug and do these assessments, because I think that's certainly a different competency of maybe the home care nurse or the home infusion nurse, that they are skilled in doing those assessments in the home. Because as we discussed previously, it's different than our sterile clinic controlled environment where you have access to everything that you need. You can get the patient in the right position, versus at the home. Now you're maybe dealing with, I don't necessarily have a great chair to put them in to do, listen to their lungs, or, I got pets running around everywhere and I'm trying to listen to heart sounds and these different things that, I think that's an additional layer to this, of the flip side of taking a nurse from the clinic and saying, go into the home and you can, do all your cares just like you would in the clinic. It doesn't really work that easily.
That's an excellent point, Chelsea. And as you were saying that, I was considering you were an infusion nurse. What kind of preparation and training did you have to go into the home setting?
So yeah, I was very blessed actually to work in basically an infusion department where we got to work in our outpatient infusion center. I got to work in the hospital setting. We put PICC lines in, we did apheresis, and then home infusion was actually like one of the last areas of this department that we trained to, because you train for how to give the infusions in the controlled environment first, right? You give it in the infusion center where you've got the crash cart, you've got the rapid response team that you can call, the physicians are right there, and you really hone those assessment skills and understand the drugs and what can happen when you give them. So then transitioning to the home, now you've got that foundational knowledge, but it was a lot of teaching me about being respectful of somebody's space. How do I, set up my sterile field in a place that's not controlled and sterile, right? And I think those adjustments, it was really, really eye-opening for me. And it was a really personal thing for people to have me come into their space, because you think about it, for a lot of patients, their home is maybe their safe space, where when they come into the clinic, it's really nerve-wracking. They know that there's going to be a procedure done to them, or they're going to have their port accessed, and that's very nerve-wracking for them. Well, now you're kind of invading their safe space and maybe doing some of those anxiety-provoking things in their home. And so how to approach that in a respectful manner, making sure that the patient's comfortable, explaining what I'm doing, being respectful of their space, not moving things around, while also kind of doing that really big, broad assessment of, is this a safe home environment? Do they have access to the basic necessities? Do I need to get social work involved because, they don't really have steady access to running water, which, those are the things that in the clinic, we don't always ask about because we're not there, we're not exposed to it. It's not something we always think about. So it was definitely a big transition, and I really needed that foundational knowledge in a controlled environment first before you start putting me in this like somewhat of an uncontrolled environment where I've got to take into account a lot of extra things. Supplies even was something like, am I going into this prepared with everything I could possibly anticipate I would need? Sometimes you're an hour plus away from where your clinic is. Do I have everything in my car that I need? So it's, again, anticipating even these might be the things that I need. And as we've discussed a little bit with Antineoplastics, a lot of things can happen. And so are you able to anticipate that and have the things that you need?
Chelsea, these are all great points. And it makes me want to ask, what level of training would oncology nurses need? Most oncology nurses are in an outpatient setting, they're in an inpatient setting. Home setting is entirely different. So how much and what kind of training would oncology nurses need now to transfer over these skills that they do have to being able to do it in the home setting?
Right. Yeah. And I think definitely, as I mentioned, having someone who has really good, solid foundational knowledge in the clinic, they've been giving these agents or taking care of people with cancer in a clinic setting for a decent period of time so that they have that knowledge base there. I definitely wouldn't want to send somebody brand new, nope, now you're going to go do it in the home too, and just add in all these other factors. But I think that's definitely a very interesting question, and it might pose a really interesting, cross-functional training model of, are we really the experts in administering agents and taking care of people in the home, or do we need to really be reaching out to our home care, home infusion counterparts that can give us that piece of, here's things that you want to take into account, here's things that you want to be evaluating in terms of safety, and even maybe is it checklists, like make sure these are the things that you're taking with you, these are the things you want to assess for when you're in the home and the things you want to look at, these are the things you want to make sure that you have available in your car, here's the numbers that you would call if you needed X, Y, or Z, or if something happened. And then maybe where are the hard stops? Like, when do you say, you know what, this isn't a safe environment for us to do this. We really need to reconsider what our plan is here, and maybe having to pivot a bit and say, you know what, we need to maybe do this in the clinic because it's just not safe for us to do that here. So I think there's definitely a lot of training aspects that we maybe as clinic nurses aren't expert in. We may be experts in giving the drug in this environment, but moving us to someplace else, I think there definitely would be a lot of considerations for nursing education and training prior to making that move.
I think some of the hard stops are some of the most frightening, frankly. The idea of a patient having a hypersensitivity reaction at home, where you don't have, the nurse practitioner right there and the doc's right there and then an emergency room. I mean, that I find to be really frightening to think about. I mean, how do we structure the system so that we make sure we're putting the very minimum number of these dangerous drugs, frankly, in the home setting? And how do we set up a call system, requirements for 24-hour access, emergency care, so that we can safely consider giving some of these drugs in a home setting?
Right. And I think for a lot of oncology nurses, that idea of having a patient with a hypersensitivity or an anaphylactic reaction in the clinic is scary. It's a very acute situation, and you got to give certain drugs but you have resources available to you, usually, at least at minimum. Usually there's other nurses around, right, that you can pull in and have you helping get the patient's vitals, what have you. And then to think about not just shifting into the home, but also maybe shifting into maybe a really rural area. I mean, I remember going out into places that were an hour from a big city. So what is your access to emergency services out there, and how long would it potentially take for an ambulance, let's say, to get to you if you're in the home and something happens? That's definitely something to take into consideration, that maybe it's not right for every patient. And so, like you say, maybe that's a hard stop for this patient of, you know what, we're really far from an emergency center. It was going to take EMS to get a long time to get here. This risk just is too high for us to proceed. So yeah, that would be very terrifying to try to be managing a anaphylactic reaction in a home.
And it seemed like that happened every day in the clinic when I worked, and I was the NP covering the clinic. And it was so constant. And the thought of being in a home setting and not having access to the rapid response team and all the emergency equipment, a crash cart, not to have that, seems a little frightening.
Well, I was going to say, and how terrifying for the patient, that this is happening in the home. And, they've probably been in the clinic enough to know, like, there's all of these resources around, there's all these people. I feel very safe and comfortable if something happens, that, there's people here to take care of this. But then also think about the family too. If something like that happened in the home, how terrifying for them. It would definitely be a lot to consider. I think one of the other things too that I wanted us to touch on was, there's guidelines and standards that help guide our practice. And one of the big ones with regard to administering antineoplastics is the ASCO-ONS chemotherapy administration safety standards. And one component of this group of standards is that independent double checks to verify, the treatment regimen, body measurement calculations, and the prescribed doses is occurring before the drug is administered. So this would also require 2 chemotherapy competent professionals verifying these aspects prior to administration. So how is this something that, an institution could approach if they decide to start shifting care of chemotherapy administration to the home? How would they maybe accomplish this specific piece of just the standards?
Yeah, and this has come up in numerous webinars post-COVID, where we've had an opportunity to share different practices. COVID has certainly changed the world in terms of virtual access to patients with telehealth, with phone calls, FaceTime, Zoom, lots of ways that we've been able to reach our patients during the public health emergency and have those visits paid for by the government and by payers. So one way we can also be using that technology is to have the second chemotherapy competent professional be on the other side of the phone or the camera doing those double checks. And so that's been proposed by some people as one way to do that you don't actually have the 2 people on site, that you do the second one off-site. That does require, though, that you have an EHR available, the electronic health record, and you can both be signing and co-signing that drug prior to administration.
Yep. And that's just one of the, I think, practical questions that would come up, because that's a question we get just in general about how do we accomplish this in our clinic setting when we've got staff that are kind of spread out all over the place, or we have a pharmacist that's offsite or something. So, we get that question just even in, let's say a routine environment. So I would imagine this is something that would definitely come up for practices of, well, how do we continue to follow the standards and make sure that they're upheld if we're shifting to this other type of care environment? So just wanted to bring that up as one of those more practical challenges too. And I think we've kind of talked a little bit about some of those key considerations of if a practice were considering shifting some of their cancer care into the home, whether it's due to the COVID-19 pandemic or they were already starting to think about that transition before the pandemic, as you mentioned. So I don't know if we want to delve into maybe just a little bit more if there were other considerations for them to take into account. I know we just talked about the safety of the nurse going out, but are there other ones that you can think of that we want to touch on?
I know we also talked about liability issues for the nurse, for the physician ordering the treatment, for nurse practitioners ordering supportive care or renewals of the treatment, that if something goes wrong in the home setting, where does the liability lie? And how can nurses be using, say in an emergency case, a state-specific nurse-initiated protocol, say for adverse reactions? Not all states have these. Chelsea, I know you were talking about this as well in another conversation. If we don't have those nurse-initiated protocols where we can jump in and start an EpiPen, steroids, oxygen, how not only can nurses be most careful, safe, and also responsive to emergency conditions, but also what's the liability if something doesn't go right?
Right. Absolutely. Yeah, I know that was a struggle that I encountered when I worked for a system that had multiple state sites, that we had a nurse initiated protocol for anaphylaxis, but the other state sites couldn't use it because nurses weren't legally allowed to use nurse initiated protocols there. So that's a big difference of precious minutes that we're delaying giving something like epinephrine that could be a life-saving medication in those instances. So even having the ability to start giving those drugs might vary place to place.
Yeah, absolutely agreed.
Some of the other considerations we already touched on. So we talked about patient family safety, talked about nurse safety. We've talked a little bit about training of, the nurses when they go out, like, do they have knowledge of adverse reactions, symptom management, those unique side effects. We talked about like cleanliness of the home. But one thing I did want us to touch on a little bit too was the actual drugs themselves. So are there considerations related to the transportation of these drugs, that now they're going to be maybe in the trunk or the backseat of somebody's car? What about the disposal of them? Those would be maybe some other things that need to be taken into account. I don't know if there's anything else in that category that you can think of as well.
Yeah, well, sure. There's certainly the stability issues of these drugs. I mean, we've all seen drugs that are sensitive to light and changes in temperature. So there would have to be that ability to transport and maintain these controlled conditions for certain drugs used in cancer treatment. And then, of course, the security issues related to some of the drugs and the equipment that a nurse would have.
Definitely, definitely. And I think maybe the last thing too that we might want to touch on in terms of considerations would be like communication. I think that might be a big factor of whoever's in the home, how are they communicating back? Who's available to this patient after they get an administration of a drug in the home? Is there a line, like a number for them to call 24/7? And then even like the documentation piece, like you talked about, do they have access to the EHR from the home?
Yeah, these are all important considerations because you want to be able to have access, not just to document the care specifically, but to actually look back in the EHR and say, gee, did this happen before? Have they had cough for a while now? And, or is this a new onset of a cough, right? You want to be able to look backwards as well. So having that ability to reach the EHR when you're in a home setting is essential. And then the other part of that is we have to make sure, like we do when we're in outpatient settings or in the hospital, when we have adverse events to drugs, and particularly some of these newer drugs that are out where we're still learning about what are the adverse events, we want to be able to document and notify the manufacturer and use the FDA MidWatch system to be able to document on a formal level adverse reactions.
Definitely. So you've been involved in, sounds like, several discussions about the risks and the benefits of kind of broadening this scope of therapies that would be suitable for home infusion. So when someone's deciding or an institution's deciding on the feasibility, or these discussions are happening about whether it's feasible to move some of these infusions into the home, what's something that you wish you were hearing more discussed, but it's not really getting the conversation it deserves?
Yeah. I think we are starting the discussions, which is good to hear, and I think is evolving very quickly right now. And I think COVID has made that happen. Anything we can do to make it easier for patients, decrease their risk, decrease their anxiety about having to come into the hospital, having to even get to their labs, right? Wouldn't it be great if they can get all their lab work done at home too, and save those short trips into the hospital? So I think where I am most cautious about, and I think there's two things in particular. One is the level of training of the person going into the home, to have a background in oncology, to understand cancer and cancer treatment, and understand the very specific regimens that are part of cancer care. And that includes how to safely handle, administer, and dispose of hazardous drugs. This is really important. I think we also need to be looking at specific drugs and whether or not they can be safely given in the home at all. If they can be safely given in the home after one first observed infusion in a controlled setting, like an outpatient cancer center, or whether they should never be given, right, in a home setting. So, I think that there are some drugs where it's probably fine for a visiting nurse to give a growth factor, right? That could be a simple thing if they're not using an on-body injector. I think a visiting nurse without a lot of oncology background could probably give a growth factor. On the other hand, should a nurse be giving some of the new drugs like the Herceptin or Herceptin Perjeta, a new subcutaneous administration in a home setting when they don't understand some of the adverse events that can happen with the injection of these drugs, which have routinely been given in an outpatient center where you have that available care? There's also we've talked about some of the other drugs that have come up, including interferon being one that we could probably give in a home setting with an oncology nurse who understands cancer and who's chemotherapy competent. So I think we have a lot more discussions to go to understand what are the considerations for training of the nurses, including, as you and I talked about today, preparing them for care in a home setting. And what's the appropriate setting for the delivery of these antineoplastics for cancer care?
Great. So as we're kind of starting maybe to wrap up here, are there any resources that you would point people to related to, let's say, home infusion or, specifically the infusion of anti-cancer agents?
So right now we're developing more and more expertise in understanding what can safely be given in a home setting. And I think it's important for nurses to advocate for patient safety. We have a duty to care, of course, during this pandemic, but we also have to be the ones advocating for safe and effective care in the right setting, given by people who understand cancer and the specific needs of people and their families, understanding the specific needs for people with cancer and how to educate them and their family caregivers so that they're getting the best possible outcomes. Because it isn't just about delivery of the drug. It's about making sure that patients are doing well, that they're not having adverse events, that they're having good quality of life, and they're being able to take care of themselves. That self-management and symptom management in the home setting is appropriate for that patient. The people who best understand that are usually oncology nurses.
Yeah, I think that's a great point for sure. I guess lastly, I know we've talked a little bit about COVID-19, and I think it would be good for us just to touch on that briefly. Are there any resources? I know there's so many out there now, but is there any resources you would want to highlight related to COVID-19 that would be valuable for oncology nurses?
We've been a bit fortunate, Chelsea, you and I, to work at the Oncology Nursing Society and be part of a very active and responsive group that has been compiling and monitoring resources for COVID, as well as resources for people with cancer and for oncology nurses caring for these people. So the Oncology Nursing Society has a webpage specifically devoted to resources for COVID-19. The organization has been very active in looking at the issues related to personal protective equipment. Oncology nurses have traditionally used personal protective equipment so that they can safely administer hazardous drugs. And in this world, they understand PPE well and have had to make decisions about what's in the best interest of patients in preventing COVID infection, at the same time delivering hazardous drugs. So we have interim guidelines for personal protective equipment to help with the decision making. Secondly, we have recommendations created on staffing during COVID-19, and that's staffing specifically for oncology nurses. Where can they be working safely and return to an oncology setting where people are at risk for COVID infection and adverse events? What do we need to be saying about how to safely staff our not only COVID units, but our oncology units? And what does that mean? So there are interim recommendations also on that COVID-19 site of the Oncology Nursing Society.
Yep. And I would just like to reiterate kind of what you were saying, Lisa. Like, we've really been trying to listen to our members and oncology nurses on really what they've been needing throughout this COVID-19 pandemic and trying to create resources to support them. And so you can find all of our COVID-19 resources right from our ONS homepage, actually. So as we wrap up, Lisa, is there anything else that you'd like to share? Any last thoughts about home infusion of cancer therapies and the COVID-19 pandemic?
Yeah, I think this has been a great discussion, Chelsea. Thank you. I think we're all going to be learning a lot more about this. I think the genie's out of the bottle. I think we've been saying that about telehealth and how much that's changed care. But I do want to reiterate that nurses have been working in home settings for many years. Nurses have been using telehealth for decades. We're very comfortable with flexing how we deliver care, but we're going to have to develop safe training and policies so that we make sure that the care that we decide to give in a home setting is provided in a way that's safe for patients, safe for family and caregivers, and safe for the nurse.
Absolutely. Well, this has been a great discussion, really relevant, I think, for current world and even as we start looking towards the future. So thank you so much, Lisa, for joining me. It's been a pleasure.
Thank you, Chelsea.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.